Good evening, everyone, and a very, very warm welcome to yet another learning series presented by ANEI's Patient Safety Fellows. We are very, very honored that we have kept up our word throughout the year, and this is our second last one. There'll be one more to go this year, and next year, sure, we will have another series of some other, sessions being done by Patient Safety Fellows. So, thank you everyone for joining. That's a good number. We got more than 45 here. Just give me a second. I will share a few slides before I hand it over to today's presenters. So, you are attending the monthly sessions and being hosted by ANEI Patient Safety Fellows. For those who are not aware of this program, I'll very quickly, briefly mention. Association of Nurse Executives India has got a fellowship program running in collaboration with Patient Safety Movement Foundation from USA. And our fourth cohort has been inducted. So every year we induct, after applications invited from any members and scrutiny, interview, etc., 7 to 8 people, senior, most of them are seniors. And this time we got very, very senior people doing the fellowship with us. And we are very honored to have all of them with us. And they put in 2 years of their time. First we were studying, then obviously everything ends with a quality improvement project, followed by them mentoring the next cohort of people. So look out for announcements, etc. next year. If you are interested, and those of you are not yet ANEI members, please become a member and empower yourselves with all the opportunities that ANEI brings to all of you through various sources. So this year we had committed that ANEI Patient Safety Fellows will conduct these learning sessions, and all of them have been done. And now we are sitting in November, and this year our focus was on evidence-based practices. So what we have done is we actually go through those articles which gives evidence-based practices, and our fellows, they go through it, they study it, they make a presentation, and then they come and do it in a webinar. So you see two facilitators, they are the fellows with the previous mentors. That's what they are presenting here. So, I don't need to repeat. This is just once again a reminder to all of us that, evidence-based practice in nursing is about giving quality care based on most up-to-date research and knowledge rather than traditional methods, advice from colleagues and personal beliefs. So, that is not our science of nursing is about. We should know what is the latest evidence based practices and whatever knowledge is out there. So in this 1 hour, our ANEI Patient Safety Fellows, they try to, bring information on that. Oh, there we have one slide. This is from last month. This was hand hygiene. So in November, we are right now, we have got Ms. Krishna Choudhury and Ms. Ramya S presenting preventing pressure injuries. Now, this is a very, very common problem for all nurses, and this is one topic no students can ever say not aware of that. So this is very important for you to know. And the next in December, we will have, ventilator-associated pneumonia being presented. Hopefully, we should do it before Christmas comes in. And then we already have the new year coming in. So how very quickly this year also has passed. And with a huge gratitude to all of you present here, it's my pleasure to hand over to Krishna and Ramya. Please come on the video and take over the session. Thank you so much to both of you. And I'm right here. I'll manage the back end and I'll come in at the end. Okay?
Thank you.
All right. Over to you. Okay.
Good evening, everyone. Welcome all of you to one of the series of learning webinars on prevention of pressure injuries organized by Association of Nurse Executive India. I am very honored and privileged to be one of the part of the ANEI Patient Safety Fellowship Program, and I want to extend my deepest gratitude to our respected Thankam ma'am for her constant guidance in for preparing these webinars in a monthly basis. So I am Krishna Choudhury, and I am working as a associate professor in Mathura Nath Memorial Nursing Institution, and my co-presenter is Mrs. Ramya.
A very warm good evening to one and all present here. I'm myself Ms. Ramya, working as an assistant professor from Ramya Institute of Nursing Education and Research, Bangalore. I thank Associate of Nurse Executives India and Ms. Tankam ma'am for the wonderful opportunity for both of us to share and insights about prevention of pressure injuries. Without further ado, I would like to request Ms. Krishna to start with the session. Krishna, over to you.
Okay, give me a few minutes to share my slides. Are the slides visible, Ramya ji?
Yes, Krishna.
Okay. So today we will be presenting on preventing pressure injuries. Though one of us, we are as a nurse, we are already having a few knowledge, and we are practicing in the hospitals how the pressure injuries, how to deal with the pressure injuries, or how to prevent it. It is just a quite mop up or refreshing session on prevention of pressure injuries. Before we start, we will just go through a clinical scenario. Mrs. Asha, a 60 years old female with a history of diabetes mellitus, since 10 years was admitted to the ICU following a stroke. She was bedridden, hemodynamically unstable, and required mechanical ventilator for respiratory support. Her Braden score was upon admission was 12, and during the clinical course, during the stay of Mrs. Asa in the ICU, for 14 days, her condition was stabilized, but she became less mobile due to persistent weakness. Unfortunately, during her ICU stay, Mrs. Asha developed pressure injury, and the wound was deep with visible subcutaneous tissue and signs of local infection. So, this is the clinical scenario, and I hope at the end of the session, we will be able to analyze the root cause factors, why this happened, and what are the learning outcomes. With this, we are presenting our objectives of today's session. The first objective is to understand the clinical impact of pressure injuries. The second objective is to identify and implement evidence-based prevention strategies regarding pressure injuries. And the third objective is to engage patients and families in pressure injury prevention. With this, we will go to the incidence of pressure injury. So, a study which has been published in the Indian Journal of Medical Research in 2015, it has been seen that majority of the patients are ICU patients, that is 38% are in ICU. And why ICU patients are most vulnerable in developing the pressure injury, we will be discussing in our session. There are various risk factors. After this, followed by the ICU patients, 31.7% are the elderly patients in long-term care. And we will also see that elderly patients are also at the highest risks of developing pressure injuries, followed by 15% generalized hospitalized patient in the indoor departments. Coming to the definition of pressure injuries are actually known as the other terms which are known as decubitus ulcer, bed sores, or pressure ulcers. And pressure injuries are the localized damage to the skin and the underlying tissues, especially over the bony prominences, which happens because of prolonged pressure and pressure associated with moisture, shear, and friction. And there are various stages of pressure injury, which we will be discussing later. But if it is not prevented or treated properly, it may lead to further complications. Now we will see the risk factors of pressure injuries. The first one is the age. Age is age is a very much like highest risk factor, because in elderly patients, what happens? There is a poor circulation and the skin integrity becomes impaired as the elasticity of the skin is reduced. So that's why the elderly patients and patients with an advanced age are at the greatest risk of development of pressure injuries. There are various intrinsic and extrinsic factors though. Second one is immobility and limited mobility. So the patients, those who are immobile and less mobile, who cannot reposition themselves due to various illnesses, injuries, or any other conditions, those who are bedridden or confined in the bed or wheelchair are at the greatest risks of development of pressure injuries due to poor circulation. The third risk factor are the chronic illnesses. Chronic illnesses like diabetes mellitus, vascular diseases can put the patient at risk of development of pressure injuries. Next is the decreased sensory perception. Decreased sensory perception in the sense, if the patient is neurologically impaired and have suffered from stroke or spinal cord injuries, they will not feel the pain or discomfort in the areas. So that's why they are having a less perception regarding the pain and discomfort, which lands them in a risk of developing pressure injuries. Certain medications are also there, like sedatives or pain relief medications, which will act on the central nervous system, which will lead few patients in the risks of development of pressure injuries. And the malnourished people, in whom the protein intake, calorie intake, and the intake of vitamin C and zinc are not adequate, for them, they are at very much risk, and they are very much vulnerable for development of pressure injuries. With this, I will request Ramya Di to continue with the causes of pressure injuries. Over to you.
Yes. So as Ms. Krishna said that we have discussed about the definition and the risk factors. Coming to the causes of pressure injury. So there are various causes which may lead to pressure injury. So the first cause would be pressure. So when the patient is in sitting position for a long period of time, or like when the patient is sitting in a chair, or when the position is not changed for a long period of time, the blood flow to the tissue is automatically reduced. So as we all are aware that the blood flow is essential to deliver oxygen and nutrients to the tissues. So because they are the key component to deliver blood. So what happens when there is no adequate blood flow? Naturally, the tissue will get damaged. Thereby, it causes the pressure is leading to pressure injury. Then the second cause would be shear injury. So for shear injury, I could just give two examples. One is when the patient sliding down from the bed. So for example, when the bed is raised and we are trying to pull down the patient, at that time, the skin moves down where the underlying tissue goes up, which makes the middle layer of the skin to shear. This could be one thing which may contribute to pressure injury. The other one is like ill-fitting wheelchairs, where when the patient is sitting in a bad posture due to ill-fitting wheelchair also may cause a shear injury. This could be the second cause which leads to pressure injury. And the third cause would be friction. So this friction happens like when the skin, when the skin rubs against any clothing or bedding. So when we are trying to pull the bedsheet, or when the bedsheets are dragged across the patient skin, the friction can lead to blisters, and which may lead to pressure injury. The next cause would be moisture. So this is a much important one that we have to notice. So excess moisture from urine, feces, sweat, and exudate may lead to maceration of the skin, especially the incontinence is a one which leads to moisture, where the moisture promotes to cause the pressure injury. The next cause is temperature. So generally when the temperature is elevated, so what happens is it may lead to perspiration. So this perspiration gives the space for the moisture to happen. So when the moisture is getting too much accumulated, which may lead to pressure injury. So coming to the next cause, we have comorbidities. So in comorbidities, the highest would be diabetes mellitus, because it has a direct risk factor for causing pressure injury, because it may have a direct effect on the blood circulation and causes other skin changes. And apart from that, the other comorbidities would be neurodegenerative disorders, cardiovascular disorders, and when the patient is on medical devices and immobility devices. So these are the causes of pressure injury which contribute to pressure injuries. The next one would be the sites of pressure injuries. So we nurses are responsible to assess the sites of pressure injuries. So we have to give more importance to the bony prominences. So we must have knowledge on about when the patient is in different positions, what are the common pressure sites. So when a patient is in a supine position, we have to look in the occiput region, that is back of the head, shoulder, elbow, buttock region and heel region. And when the patient is in a supine position, we have to check in the earlobe, shoulder, elbow, hip, thigh, leg and heels. Whereas in the patient is in the prone position, we have to check for elbow, rib cage, thighs, knees and toes. But here I would say that apart from assessing these sites of pressure injuries, we also must assess when the patient is on medical devices and immobility devices, such as when the patient is on nasogastric tube feeding, endotracheal tube, indwelling urinary catheter, any immobilization devices, cervical collar. So such things also, and oxygen tubing. So we have to give attention to these things also when we are assessing for the pressure injury. So we must be aware about the sites of pressure injury in terms of position, in terms of medical devices and immobility devices. Coming to the pressure injury assessment tools. So in terms of risk and skin assessment, we commonly use Braden scale or Norton scale and pain assessment scale. So we all are aware that this Braden scale is the most commonly used scale in the clinical setting. So which gives you an idea of to which extent the patient is developing the pressure injury. So the commonly used Braden scale, we all are aware that it contains of 6 components. So audience could just put it in your box that what are those 6 components that we are using to assess the Braden scale to identify the pressure injury. So you can just post your answers in the box. So then apart from this, yeah, it's right. It's sensory perception, nutrition. Then we check for the friction, wonderful answer. And we check for the mobility, yes. And we check for the apart from mobility, nutrition, one more important also we check. Any audience would just want to tell the answer. One is, yes, wonderful, share and friction. So what could be the score is, the score ranges between 6 to 23. And how are we determining that the patient is suffering from pressure injury is, when the score is low, it indicates that the patient is at high risk of causing a pressure injury. So the other important thing is assessment of pain. So to assess a pain when the patient is on pressure injury, we use commonly visual analog scale and verbal rating scale. Apart from this risk and skin assessment, we also carry the next assessment is daily reassessment. So in daily routine reassessment, we do the daily reassessment. So when do we do this daily reassessment is, like, for example, when we are admitting at the time, admitting the patient at the time of admission. And then what are the other ways that when we shift the patient from one department to another department, we have to do this routine reassessment. And when we transfer the patient from one stretcher to wheelchair or wheelchair also, we are expected to do all these assessments. And not only that, we also must focus on pressure points which need to be checked while repositioning the patient. And there is something called pressure injury classification system. The National Pressure Ulcer Advisory Panel system has given the stages of pressure ulcer. So we nurses are ought to know the stages of pressure ulcer in order to identify which stage does the patient belongs to, so that we will be able to rule out the patient is at which stage and what type of intervention can be provided at the earliest. That plays a major role in prevention of pressure injury. So with regard to the stages of pressure injuries, we have 4 stages of pressure injury. So the stage 1 is where you could see in this picture, we must identify that it is a non-blanchable erythema. We can see the wound will be, usually the skin is red in color. We have to pay attention the moment when the skin starts to be red in color. So that is one of the early indication that the skin is damaging, but there will not be any open wound as such. But when we touch the wound, we may feel that the wound is warm or cooler. and the pain is in the surrounding tissue. So this is how we have to identify stage 1. Whereas in terms of stage 2, you could see clearly there is a partial thickness skin loss where it involves the epidermis. So here you could see the wound looks open, yes, and it looks shallow. And the color of the wound bed would be either red or pink in color. So this is how we are differentiating from stage 1 to stage 2, whereas in stage 2, we have an open wound. So coming to the stage 3, we can see that you can see that there is a full thickness skin loss. So we can see visibly the fat, but we will not be able to see bone, tendons, or muscles will not be exposed. I could say that there will be a roll of, there is something called roll away, where we call that as an epibole. So here we cannot see visibly the bone, tendon, or muscle, but we can see visibly the full thickness skin loss. This is how we identify stage 3. Then in terms of stage 4, we can see that the full thickness tissue loss, where the bone, tendon, muscle is also exposed. Sometimes there will be a slough or eschar formation. And this stage 4 may further lead to deeper damage, which includes the tissues, muscles, and bones. So we nurses are expected to know this stages of pressure injury in order to identify to which stage does the patient belong to. So coming to the prevention, so we next, the prevention strategies will be explained by Ms. Krishna. Krishna, over to you.
Thank you, Dee. So in prevention strategies, pressure injuries are always considered as one of the significant patient safety indicators. And there are, if pressure injury is reported, then there is a reporting that there are lack of care from the nurses end. So that's why we have to first focus on the preventive strategies, how to prevent the development of pressure injuries. The first one is initial assessment. Initial assessment is the one when the patient gets admitted to the hospital. It is the role of the nurses. Our role is there to assess the patient. So first of all, as my co-presenter, Ms. Ramya has already told that we have to assess for the risk factors. Risk factors through standardized tools like braid and scale, and we have to see all the parameters like for what the why the patient will be at risk for development of pressure injury. Suppose, for example, if a patient has been admitted in the case scenario, also we have already discussed that Mrs. Asha was diabetic. So diabetes is one of the comorbidity, and it is an like comorbidity, and it can complicate as a peripheral neuropathy also, where the patient is at risk of development of pressure injury. So we have to first of all assess for the risk factors. Next, we have to assess the skin. We have to assess the skin, like if there is any skin breakdown, dryness of the skin, any abrasion is there or not, with special attention to the bony prominences. We have to check and assess the bony prominences. And also we have to review the medication history. If the patients are on sedatives or any other analgesic medications or any other medications which may affect the which are acting on the nervous system. And we can also go through the medical history of the patient, whether the patient is having whether the patient is malnourished or he is having any vascular illnesses or any other comorbidities. Next is the daily reassessment. So when the patient has been admitted in the ward, we have to do a daily reassessment, that also focusing on the risk factors, whether in a daily basis the patient is prone to develop pressure injury. If the patient is immobile, suppose if the patient is shifted to the ICU and the positioning is not properly done, the patient cannot move by themselves, then that is one of the risk factors which can lead to the development of pressure injury. So daily reassessment of all the risk factors along with special attention to the skin need to be done. So this is about daily reassessment. Next is the skincare. So moisture is one of the cause of pressure injury. If the patient is having incontinence or there is profuse perspiration, then the patients will be at risk. So in skincare, we have to keep the skin hydrated and dry. We have to use moisture barrier products and mild moisturizers, which is non-irritating to the skin. and we have to apply the moisturizer daily. But one thing we have to keep in mind, we should not do a vigorous massage, or we should not rub the skin if the skin is having a risk. If there is a non-blanchable erythema, we should not rub the skin of the patient, and vigorous massage should be avoided. Next, coming to the provision of supplies. Provision of supplies in this context, I will tell you regarding the provision of pressure relieving mattresses or heel protectors, pressure relieving mattresses like air mattresses, foam mattresses, water mattresses, which are available in the hospitals. Heel protectors need to be there, skin care products need to be there, so that we can take care of the patients while preventing the development of pressure injury. As in the previous slides also, I have mentioned that nutrition and hydration is one of the most common risk factor for the development of pressure injury. We have to assess the nutritional need of the patient. We have to assess the daily caloric intake and protein intake, and supplemental nutrition like supplemental protein or vitamins, zinc supplementation need to be provided in coordination with the dietitian or nutritionist, and the patient should be hydrated throughout the day. We have to also monitor the intake and output chart, because dehydration is one of the factor which can lead to skin breakdown, and there can be a development of pressure injury, so the patient need to be hydrated. The next is repositioning. So we have to reposition the patient at risk every 2 hourly. And during repositioning also, we have to check that while giving the pressure relieving mattresses, the pressure of the body prominences are equally distributed. And 2 hourly repositioning is mandate. We can give various positions like founder's position, or it can be right or left lateral position depending on the patient's condition, 30-degree tilt. So these positions we can provide to the patient, but that also depending on the patient's condition if it is not contraindicated. Use of support devices like pressure relieving mattresses, I have already told, air mattresses, foam mattresses, water mattresses, and the heel protectors. Also some additional supplies like pillows or wedges, rolls, blanket rolls can be used so that we can support the bony prominences. And the last one is family involvement. Family involvement is very much essential, because if the family members will know regarding the risk factors, why a pressure injury can develop, and how they will assess the skin, those things need to be we have to educate the family regarding the risk factors and how we need to assess the skin of the patient. And also if there is a development of wound or pressure injury, how to take care of it for preventing further infection, that need to be focused. With this, these are the preventive strategies which we are employing in our hospitals in a daily basis. But even though if the pressure injury has developed, then what are the treatment protocols? We will focus on that. These are some preventive care strategies. As we have already discussed, initial assessment need to be done within 4 hours of admission, and daily reassessment. In this, we have to monitor the condition of the skin of the patient, and in monitoring the skin condition, we will see for any breakdown of the skin, redness of the skin, whether it is blanchable or non-blanchable, and the condition of the skin we will see. We will maintain basic hygiene and cleanliness of the skin. Skin need to be hydrated, and moisture barrier products need to be used to prevent moisture, which can lead, which are the risk factors of development of pressure injury. And we can also use absorbent pads if the patient is having incontinence or perspiration, or if there is any wound drainage, we can use absorbent pads and mild cleansers to clean the skin. And mobility can be ensured by support devices like pillows and heel protectors. And we can also engage the patients and families in the care strategies for the patient. So even though after all the preventive strategies has been employed, if the patient landed up in a pressure injury, what is our role in the treatment of the underlying causes? The first one is infection prevention. For infection prevention, we have to, can the audience just write in the chat box what kind of infection prevention strategies we can apply in the hospitals, which we are applying in a daily basis.
Krishna, they have mentioned as silicone foam dressing.
Okay, we will come to that. Any other infection prevention strategies?
Hand
Yes,
wash. Wonderful
hand
answer.
hygiene. Yeah. So hand hygiene is one of the most effective measure to prevent infection. In the previous webinar also we have learned in depth about hand washing. Like with hand washing also we can use the alcohol rubbed hand sanitizers. And if there is a wound, development of wound, we have to use sterile supplies and equipments while taking care of the wound. While dressing the wound, we have to use all those articles, and articles need to be sterilized, and the environment or the surrounding of the wound need to be sterile. The next one is wound cleaning. So in wound cleaning, to remove the debris, sloughs, or the necrotic tissue from the wound, we can use normal saline, which is non-irritant, which will not cause irritation to the skin. I would like to know what the nurses, or those who are working in the hospitals, what they are using as a wound cleanser. If there is a development of pressure wound, what kind of wound cleansers they are using in the hospitals? Normal saline. Yes. So normal saline, it is non-irritant, and we are using normal saline to irrigate the skin, irrigate the wound, and it is like we are recommending normal saline for cleaning the wound to remove the debris. And we should always take care that there should not be any remaining debris, any slough, or any type of necrotic tissue which can impede the healing process of the wound. Next is wound dressing. So wound dressing, it depends on the size of the wound, the condition of the wound, and the stage of the wound, what type of dressing we are going to apply. So there are various types of dressing, like foam dressings. One has already mentioned foam dressing. Hydrocolloid dressings are there, which can absorb the exudate. Then alginate dressings are there. Transparent film dressings are there. Silver infused dressings are there. I want to know most commonly what type of dressings are used in the hospitals. You can just give your responses in the chat box. Comfil dressing. Any other dressing commonly used in the hospitals? Silver alginate dressing, hydrogel, silver nitrate dressings. Yes, that will absorb the exudate, and we can have a look on the condition of the skin. Okay. The next one is consults and referrals. So for treatment of the pressure injuries, depending on the risk factors, we have to consult the wound care specialist. Wound care nurses are also available in the hospitals, where they will deal with the wound. They will use the push tools for identifying the depth of the wound, and what stage the wound is, and what is the type of exudate. Along with the wound care specialist, we can also consult the physiotherapist for early mobilization of the patients, nutritionist and dietitians, so that they can consult and assess the nutritional needs of the patients. And along with that, we can also consult with the infectious disease specialist. If there is any infection in the wound, then we can, local infection or systemic infection, we can consult with the infectious disease specialist also. Next treatment is pressure distribution. This we have already mentioned in the preventive strategies. So here we can use the air mattresses or foam mattresses, so that the pressure will be equally redistributed. And these supplies are easily available in the hospitals. Next is the physical therapy. If the patient's condition allow, we can give them some muscle strengthening exercises by the help of the physiotherapist. And if they are bedridden, we can apply the range of motion exercises, whether it can be active or passive exercises. We can do the exercises onto the bedridden patient if the condition of the patient allows. And repositioning is equally important. And nutrition and hydration need to be maintained. So here it is advised that for a patient who has developed pressure injury, 30 to 35 kilocalorie per day extra kilocalories need to be given, whereas from 1.25 to 1.5 gram of protein per kg of the patient need to be given. Here the nutritionist will have a role. The dietitian of the hospitals will have a role where they will assess the nutritional needs of the patient, and accordingly they will give the dietary supplementation, because along with the protein intake, vitamin supplementation of vitamin A, vitamin C, and zinc is very much necessary, so that the tissue will be healed, repairment of tissue will be there. And equally, the patient need to be hydrated, because as I have already mentioned, that dehydration is one of the risk factor which can lead to impaired skin integrity, and it can be a risk factor for development of pressure injury. And if there is a development of wound, we have to reassess the wound every 2 hourly or 4 hourly according to the hospital protocols, and proper documentation need to be done. Reassessment in the sense that we have to check the size of the wound, then what type of exudate is there, whether it is infected or not, if any local infection is there, what type of dressing is being used, and what type of wound cleansers are used, and we have to check the stage of the pressure injury. So this documentation is very much important after we are reassessing. So if an ulcer has developed, we have to obtain wound care specialist input. That can be a wound care specialist or a wound care nurse. So they will be very much specialized regarding the condition of the wound. So we have to obtain their expertise. In ulcer management, we have already told that non-toxic solutions like normal saline can be used for cleaning the wound. And according to the size of the wound and according to the exudate of the wound, we have to apply appropriate dressing based on the classification given by the National Pressure Injury Advisory Panel. And in documentation, we have to record the size of the wound, the tissue type, whether it is a necrotic tissue, it is a slough or a granulation tissue. So how can you identify necrotic tissue, what is slough and what is a granulation tissue? Can the audience just write the responses in the chat box regarding necrotic tissue, slough and granulation tissue? Necrotic eschar. Necrotic eschar, it is black in color, and slough is the yellow or white colored the exudate which can be seen, and in granulation tissue the tissue is healing, it can be pink in color. And we have to see the odor. If there is any foul smelling odor, then it can be a sign of infection, and then we have to document the stage of the pressure injury. And if there is any signs of infections like fever or redness in surrounding the wound area, warmth, and this area has been swollen up, that need to be documented and appropriately reported. So when a patient is planning for the discharge, we have to prepare for the transition. Transition means the phase from the hospital when the patient will be discharged to the home or any other healthcare facility. There we have to document. Again, we have to use the standardized tools like bread and scale, and we have to document the risks for the development of pressure injury. And also we have to assess the skin if there is any new areas of prone to develop pressure injuries, and if the pressure injury has already developed, what is the condition of the wound, that we need to document, and we have to prepare for the discharge. And regarding patient and family education, we have to explain all the daily preventive steps to the patient's family, and specific risk factors need to be emphasized. Specific risk factors, like if the patient is immobile, then we have to engage the patient we have to educate the family of the patient to engage the patient in a physical therapy or some muscle strengthening exercises. So those, according to the individualized risk factor, we have to tailor the plan. Now with this, I will request Ramya Di to continue with the pain management in pressure injuries. Over to you, Dee.
Thank you, Ms. Krishna. So you had very clearly explained about the prevention strategies of pressure injuries. Yes, of course, the pressure injury can be prevented if we are witnessing at the earliest. But once the pressure injury is developed, we are also ought to know about how to manage pain in pressure injury. So in that case, we have to do the routine pain assessment. As already we have said that the pain assessment can be conducted using a visual analog scale or verbal rating scale. So we have to do that on a regular basis during every shift. That could be the first strategy that we have to do. And apart from that, we have to document the pain level and we have to use the pain strategic measures according to the pain of the patient. With regard to the routine pain assessment, so one is pain assessment, another one is documenting the pain level. So the next would be, apart from routine pain assessment, we have some of the non-pharmacological interventions such as repositioning and using the supportive devices. So here we use the redistribution techniques. So what is this redistribution techniques is? These are the strategies and the equipments that will help to distribute the pressure evenly across the patient body, which will help to reduce the risk of pressure ulcer. So in that case, some of the redistribution techniques or devices that we can use is mattress, where we can use foam mattress, gel mattress, or air cell mattress. We can use some cushions. So especially these cushions must be used in wheelchair, or because this will help to minimize the pressure. And apart from that, we can use the air fluidized beds, turning beds, orthotic devices, heel lifts. These are the some of the devices that we can use as the redistribution techniques, which will help to relieve discomfort. And not only that, it also helps to reduce the pressure ulcer. Apart from that, some of the comforting measures, especially when the patient is on lines and tubes, we have to think about padding, provide adequate padding, adjusting the bedding, and maintaining the wound is a very important thing, where we have to ensure that the wound is kept dry. So because we know that moisture is one of the reasons that which may further provoke the pressure ulcer, and these are some of the non-pharmacological interventions which would help to reduce the pain in a patient with pressure injury. Apart from that, we have some of the pharmacological measures. So those pharmacological measures are where, for example, when we are trying to go for a dressing change, so if the patient may have a pain, so if we need to reduce the pain, we can use some of the topical anesthetics. So I would just request the audience to just list out few topical anesthetics that we use to reduce the pain before performing a dressing. So audience, please, you could just post what are the, yes, lignocaine, then. So we can also use some of the topicals called as sevoflurane. Apart from using this topical anesthetics, we are using some analgesics such as naproxen sodium also can be used to reduce the pain. So this could be the pharmacological pain management, where which will help to reduce the pain. Apart from pharmacological, non-pharmacological and redistribution techniques, we must also educate the family members in terms of patient education. So in family patient education, so we have to provide the importance about how to identify the stages of ulcer, because most of the patients come to the hospital when they are in stage 2 or stage 3. So we must teach them, and we have to take feedback from the patient whether they have understood on how to identify the stages of pressure injury. We must teach about the importance of positioning, repositioning, then how to clean a wound, how to apply a gel, how to change a position, how many hours once that we have to change a position, and how the nutrition is also playing an important role in helping of the wound to get healed. So we have to involve the patient and the patient caregivers in order to reduce the pain. So these are the pain management that we have to do during pressure injuries. Apart from that, we just go for the surgical interventions in pressure injuries. So some of the surgical interventions would be debridement. So this debridement is indicated not for all the stages. So when the tissue looks to be necrotized, or when we feel that there looks to be an infection, or it is a non-healing tissue, then we go for the debridement. So we all are aware that debridement, so it is one of the procedure which removes the dead or damaged and infected tissue from a pressure ulcer, which helps to promote healing. The second one could be apart from debridement, we could go for the flap surgery. So here in a flap surgery, what it will do is it helpful for the preventing the complications. This flap surgery, we have to go ahead only in case if there is a recurrence or there is a dehiscence or when there is a flap necrosis, we go for the flap surgery. The third one could be, apart from flap surgery, we go with skin grafting. So we all are aware that skin grafting is like, it is in case if the wound is found to be very large. So the healthier skin is transplanted to the ulcer site, which helps for the wound healing. So these are the surgical interventions which we go in pressure injuries. The next would be like in case if the pressure injury is not treated properly. So the following are the complications of pressure injury. The first primary would be an infection. So it is a life-threatening infection which could occur where there is a chances that the bacteria could enter directly from the pressure injury. The second complication would be delayed wound healing. So as we have discussed in the case scenario that one of the main cause for delayed wound healing is like if you could take into the case scenario, Ms. Asha, she is suffering from diabetes since 10 years. This could be one of the main cause for the delayed wound healing. And the third complication is pain. So due to the recurrence, there will be a pain. So pain is one of the main thing that need to be addressed when a patient is having a pressure injury. The fourth cause is scarring and loss of mobility. So what will happen is the scarring, when the wound starts to heal, the scarring may go and it will get other to the nearby tissue. So this scarring, when it is getting other to the nearby tissue, it may cause an immobility. The next complication is recurrence. So when it is not treated or when the patient, I mean the caregiver is not able to manage or because of other comorbidities, there is a chances for the recurrence. So when we don't pay attention to the minute things such as repositioning, assessment, and then ensuring that the wound is kept dry in terms of nutrition aspect, hydration aspect, the recurrence happens in pressure ulcer. So these are the complications of pressure ulcer. So let me summarize the topic. Sorry, before that, we would also tell the patient and caregiver education. So we must ensure that they understand the risk factors, the stages of pressure ulcer, as we have discussed, 4 stages, and the importance of skincare and how to position and what to address during positioning the patient, how to assess the level of pain when positioning the patient, and maintaining the nutrition and hydration, and how to identify the signs of infection. And we also should teach about the post-discharge plan on how to take care, so which we have discussed already. So here we are summarizing the topic. Yes, so we have looked into the definition and the nurses must be aware and take a step forward to prevent the pressure injury. So we have looked into the definition and impact and how to prevention, especially in terms of prevention, we have to focus about skin assessment, what are the pressure relieving devices and how to focus or maintain the skin hygiene, and how does the nutrition and hydration plays a role. So early intervention is the only way where we can help to prevent the progression to severe stages. And also we must know what could be the complications and what could be the, the prognosis. So, but the prognosis completely depends only on early detection. So this is about, we are summarizing your topic. So I think we all had some insights about prevention of pressure injury. So here the question is for audience. So after seeing this Asha's condition, now we all request you to throw a light on what could be the root cause analysis for Miss Asha's condition. So right now we are leaving it to audience. You can tell that what were the RCA for Asha's condition. So you have seen that she was suffering from diabetes since 10 years. And then she was admitted in intensive care unit. Unfortunately, she has developed an ulcer. Krishna, I would just request you to go back to the first slide to have a recall on the scenario so that they could able to identify the RCA.
Yeah.
So here you could see that the Braden score, it was 12. So what could be the risk? So do you all think that the patient is at high risk or moderate risk, or there is no risk? Yeah, it's correct. The Miss Sunita, she says that it is an high risk. Why do you say, Sunita, it is an high risk? Okay, so we all, yeah, Sunita, you can just tell your answer.
Yeah, good evening to all.
Good evening.
She's on high risk because she's a veteran patient and
Very
she
good.
has a persistent weakness
Yes,
and in the ICU stay and
wonderful
in the
answer.
board in the body problems are more prone to get the pressure sore.
Yes.
Thank you.
Thank you, Ms. Sunita, for your wonderful answer. And next, please kindly all of you find out which stage was Ms. Asha suffering from. See, unfortunately, she had developed the pressure injury. Well, the wound was deep with visible subcutaneous tissue and signs of local infection. So you all can say that which stage does she belong to? Stage 1 or 2 or 3 or 4? Stage 3. Yes. So why do you say, Miss Shaila, it is stage 3? Can anyone just tell your answer, like why it is stage 3? So what does the stage 3 defines thing?
Hello.
Yes.
Yeah, good evening, ma'am. Maybe I have said this stage 3 because the subcutaneous tissue is visible. That means epidermis and dermis is already affected. So we, categorize stages with the depth, you know. So
Yes.
according to me, it is stage 3. So because a subcutaneous tissue is visible, you know.
Yes. You are right, Mr. Jakir. Thank you for the answer.
Thank you.
Yeah. So what
I
could
want to ask, like for what are the root factors why the stage 3 pressure injury has developed? So can anyone just brief it? You can give your answers in the chat box also. What went wrong during her stay in the ICU? Minimum activity. Okay.
not only that, even the patient is having diabetes and then prolonged stay, and
Yeah.
it was not detected at the earliest, unfortunately. Compromised nutrition. Okay.
Yeah, I hope we were able to cover all the factors which led to the development of a pressure injury in Mrs. Asha.
So now we request Ms. Tangam ma'am to give her insights, few experiences about coming across a patient with pressure injury in her clinical experience. Ma'am, over to you, and thank you for the opportunity, ma'am.
Thank you, Krishna and Ramya. Fantastic discussion. Thank you very much. So we do have some questions in the chat box. We'll try to answer that. And I will start with a couple of questions because pressure injury is such a frequent topic being discussed. Maybe we can stop sharing the screen, please, Krishna. Thank you. My first question is, how many of you think that the pressure injuries are preventable? Yes, no. Chat box quickly. How many of you think the pressure injuries are preventable? Okay. I didn't expect anyone to write no, but are we able to prevent completely?
No, ma'am.
So the answer definitely is no. So there is a gap between what we desire and what we achieve. This is one topic that in my personal avatar, I had to deep dive because I had to create a training around module around pressure injury, prevention. So some of the things that I learned and I reflected, and reflecting back to my personal experience, some of the things that we could be doing better is that, number one, all of us agree that, developing pressure injury is unfortunately indicates the quality of nursing care.
Yes, ma'am.
Yes.
Exactly,
So
ma'am.
I don't know, in my experience, any pressure injury, I used to feel so guilty thinking that, we failed, So I think that's what everyone feels. But are we doing enough to prevent? That is a question to ask. Now, I'm going to highlight on few things that I have come across. Basic things, but we somehow tend to miss. So the first and foremost, when I was preparing, one thing that I thought what we don't do at the time of initial assessment is we tend to rely completely on the number, Braden score number. It is good, but that is not good enough, because in some hospitals, the Braden scales, the skeletal thing is available for reference. Nobody can remember everything. Now, for example, if we are assessing moisture, how will we write number 2 or 3? We say mostly moist, sometimes moist, there will be a difference between how Ramya will look at, how Krishna will look at, how Tankam will look at. So the Braden scale, obviously the Braden score gives, all clarifications. When do you call something as, partly mobile, not mobile, etc. So the complete Braden score sheet should be available to all nurses to refer, so that they can read and write the correct number, so that they are able to identify which are the areas the patient is having more risk. Is the patient at more risk because of the mobility factor, or is it because of the moisture factor, or is it because of the sensory perception? Because sensory perception, in this patient, sensory perception is also a problem because she had stroke. So if her one side is paralyzed, she will not be able to tell, guys, this side is tired, can you turn me? Because she just can't feel anything on that side. So it is our job to actually think for the patient and reposition the patient. Now in US, stage 3 and stage 4, hospital acquired stage 3 and stage 4 are called as never events. Never events means the insurance company will not pay the hospital for any treatment henceforth. Neither the patient will pay, neither insurance company will pay. So obviously that expense has to be borne by the hospital. So that reminds me, I can I can actually go on talking about this for another 1 hour. So I'm going to look at the questions and quickly answer that. Compromise capillary refill, we don't know. EMI, okay. See, one basic thing you kept on discussing was the nutrition and hydration. Okay. Developing pressure injury, poor nutrition and hydration is a risk factor. Patients who are poorly nourished and poorly drinking, they are at risk for pressure injury. Now, in reality, are we able to address that? I know for sure that all my nurses are not focused on feeding and making the patient drink unless and until the doctor is ordering for an intake and output. Every time I keep asking that, are you concerned about the patient's, position and nutrition and hydration? You did mention that dietary consult should be given so much calories and so much protein. The dietitian will only order, kitchen will bring the food. Who is going to ensure the patient actually consumes it? So these are some very practical gaps that I have seen in my personal experience, because in IC also I have seen 2-3 NG feeds waiting to be fed. And whenever I ask that what happened, why is this feed not given, everybody knows the answer. Always they'll say we were busy. Now, of course, I'll ask them that, did you give medicine? They'll say, yes, yes. So it looks like, we are very concerned about giving medications, but we are really far away from giving the nursing care that we all have learned to do. Another question is about the moisture. In science, we are learning how moisture is going to increase the risk of pressure injury and how is that going to worsen the pressure injury if it happens. But how many times our nurses will say that I did not find a help to change the diaper of the patient and allow the patient to be wet. The patient family will come and shout and say, my mother, my father was lying on the, wet bed or diaper for such a long time. So I only used to ask my nurses one thing. I'm not asking you to change the patient. I want to hear your concern. When you will give me a call and say, I want to change my patient because the patient is at risk for pressure injury, so he's always being wet. So I need help to make sure. That worry is what I was looking for, which I was not able to see. Pressure injury, all the science behind it, I am sure that most of us are aware of it, but still why we are not able to do that. So I'm just going back to Sandhya's question. Which type of patients are at higher risk of developing PI, as these patients will need? Well, it's a combination. I think all the risk factors have been already discussed. Maybe Sandhya came in a little late, could be that. So all the risk factors, not going to repeat that. Can you share your views on types of pressure injuries in the hospital? I can say that when I was in hospital, the most of the pressure injuries used to be stage 1 and stage 2. I mean, when you talk about pressure injury, the medical device associated pressure injury is a different category. This pressure injury is related to the pressure that is inherently put on the patient. So there is intrinsic and extrinsic factors that are playing. So mitigation will be based on the risk factor that we have identified. So in this particular case scenario that you gave, the control of the sugar, repositioning the patient, the nutrition, the vital signs, everything becomes very important, because there is one assessment called the physiological status of the patient, where you take your vital signs. It will tell you what is your circulation. So pressure injury already explained is that whenever there is a lack of blood supply, so that one thing that I in the last 1 year is that something called damage cascade. This is applicable to all kinds of injuries, not only pressure injury. Damage cascade means even in our body, if suppose you are going to get something, don't you feel that there is, why is it paining? You have that feeling, no? After 2 days, you'll say, oh, there is a small boil coming up. So before the boil came, you had pain because of the cell deformation. So pressure injury happens finally because of the just in the cells, and because of the interstitial edema, the capillaries are not able to bring enough blood, ischemia, death. That's how your skin start integrating. So I have got one more question to ask. When a pressure injury is formed, is it infected? Yes, no. I'll come back to IAD quickly. That is another question Sandhya had asked. Okay. Thankfully, everybody is answering no, no, no. Very good. Fantastic. It is not infected. So preventing infection is very important. My endeavor was that if stage 1 by chance happens, it should not become stage 2. After that, it should get arrested there. I think any hospital, I would say, is the ideal stage will be 0 pressure injury. But at least you can start with 0 stage 3 and stage 4. Then you say 0 stage 2. But there are some patients, I know, I'm a critical care nurse. Despite all the efforts that you have done, there is a possibility in some patients it can still happen. So one of the things that I learned in the last 1 year is the pain assessment, not for the pressure injury per se. Even before that, before the skin gives any changes, your pressure sites will have pain. And usually we don't do that. See, whenever I ask the question, what do we do to prevent? Everybody will say air mattress, back care, give the, patient, turn the patient, all those things. Nobody will talk about appropriate nutrition and hydration. Nobody will say, I will feed the patient, I will make the patient drink, so that pressure injuries are prevented and they will heal also. The other thing is, when you turn the patient, you have to do skin assessment. You showed all the pressure points. When somebody is on prone and supine, lateral, there are pressure points which are coming under pressure, right? So when you turn the patient, those sites are now relieved. So you need to look at all those sites and see that whether those areas have any changes, pressure points, and also ask the patient whether they have any pain. If the patient can verbalize, you can ask whether they have any pain, which can indicate to you that this is a early warning, that the pressure injury can come, so you can take necessary, precautions to make sure they don't develop into pressure injury finally. Now, the other question was about, yes, long duration surgery. Yes, it's a very, very pertinent, message for all the nurses sitting here, because OT is another area. Because for long surgeries, if they are not protected, they are not protected with the right, foam, pillows or whatever support is required, when they come out, they can come out with pressure injury. So my next interesting question, how long does it take to develop a pressure injury? How long does it take to develop a pressure injury? These are my very favorite question. Huh? Yes, can we get some answers, please? Yes, Sajitra, you can read the guidelines of the National Pressure Injury Advisory Panel. 4 hours. Okay. Okay. So someone told even in half an hour it can happen. Yes. In a vulnerable patient, it can develop within 30 minutes also. The vulnerability of the patient, so there are some basic, risk factors related to age, the weight, somebody was talking about BMI, activity, moisture, nutrition, hydration. So there are 7, 8, common factors. If we can address that, if we can address and find what is the major factor in this patient. So the other question from Sandhya was, incontinence associated dermatitis. How do we differentiate between the two? Very easy. Pressure injuries are on the bony prominences. And IAD is usually a diffuse, skin changes. So diffuse skin change. I'm just muting someone. So pressure injury usually has very defined edges. The IAD is more diffuse, and you will actually see a red area, maybe with some, pin spot bleedings also. It looks angry. The top layer of the skin will just go. It is almost like somebody has shaved the thing. So both the buttocks, wherever the moisture was there, so IAD and pressure injury cannot be, mistaken if you understand the way that anatomically how it looks. Pressure injuries are very defined edges, and IAD is very diffuse. And then they look very reddish and angry, and you can have, pinpoint hemorrhage spots also visible. So usually if you have seen both of them, you cannot mistake them. People should not mistake. There is one category of pressure injury which you had not discussed. Maybe it was not in that article. That is called the deep tissue pressure injury. Deep tissue injury. That is one variant. So I would like all of you to learn from this session that any pressure injury which has got dead tissue, black colored tissue, please do not stage them. Just write as unstageable. Nobody should try, even attempt, whether there is, any black colored tissue in any stage. It doesn't matter. You should not write the stage. You have to write unstageable. And other thing is, when you're dressing those wounds, no slough, no dead tissue is a prerequisite. Unless the dressing is going to do something for the dead tissue and the slough, you should not dress a pressure injury which has got slough and dead tissue. It has to be removed. The debridement has to be done. So the wound bed, you talked about, the push tool is to see the healing of the pressure injury. So it will measure the length, the breadth, and the exudate. Exudate will be there, but there should be no slough and there should be no dead tissue. Pink and red, good story. Yellow and black, bad story. So that is something one should keep in mind. And deep tissue pressure injury, the differentiation, how we find is usually the pressure injury is about reddish pink, reddish discoloration. Deep tissue will be more purplish. You could have a challenge in very dark skinned people, but it's kind of purplish. And the biggest differentiation comes when you assess, when you touch, you actually get a bogey feeling. How do you explain a bogey feeling? I can only explain a bogey feeling by saying that, it's almost like if you touch an abscess, how do you feel? There is something underneath, right? This will also feel. So what happens once the maroon looking dead tissue comes off, you will find it could be a stage 4 underneath. Entire thing will be. It's actually going all the way down. And I had only seen twice in my entire career, and few stage 3 and few stage 4 I have seen. So the feeling will be bogey. Yes, it's almost like a, abscess. You feel like that. So once you have that, you can call it as DTI. So all the leaders sitting here, those who are responsible for tracking all this, you not only track the number of pressure injury, but differentiate them into DTI, stage 1, stage 2, stage 3. And one more thing, one of the risk factor is actually asking the patient if they have come with so many, risk factors, this patient is at high risk to develop pressure injury. Please ask them a question. Did you ever have a pressure injury before? If they think, yes, last time also he was admitted, it took us months, that means your antenna should be up, that this patient is at higher risk of developing. Last time also, the patient developed. So that is something that one should ask. And I know this was not part of the initial assessment, at least when I was in Fortis. So today, if I have to redo something, probably I will add these very pertinent questions, to make sure that we are first of all able to place the patient risk category in the right way, not just the Braden score, but to understand out of that what areas are contributing to this patient and what we should do to mitigate those risks. Unless it lands up in personalized, preventive action, we will not be able to get huge success. It is better than before, but then we will not be able to get huge success there because everybody answers even today the same thing that we answered 20 years ago. Turn the patient, keep the patient dry. That's it. You mentioned about giving passive exercises, keeping the patient active. All those things, are we really doing? These are questions to ask ourselves. So I think we had a great, number of audience, more than 140 people, and there are 97 people still here and a lot of people interacting and giving answers. So looks great. Thank you so much. And so while you go, please take away with this that within half an hour also you can develop pressure injury. Not everybody develops. So one more food for thought as you go from here is that, yes, prophylaxis dressing applications are important because that is when you recognize that there are risks for certain sites, there are many prophylactic dressings which are available, which you can use to ensure that they don't break down. And something came to my head and I started reading and I forgot what I was going to tell. Unfortunately, I forgot. Thank you, Neetu, for that. Scott trigger tool for injuries. Yes. So thank you for all your interaction. So while you go, okay, I know my last thought. Please remember, vulnerability of the patient when you identify is not only related to the risk to fall. They are vulnerable for all kinds of problems. And please remember, we have no data that how many patients actually die because of infected pressure ulcer. Because we don't track them, so we don't know. We have only US data which says that, this number of patients are dying and, because of pressure injury. Now we'll wonder who will die because of pressure injury. Now, pressure injury, getting infected, becoming septicemia, multi-organ failure, gone. So we will probably forget also by the time the patient is no more to say the trigger was the pressure injury which got infected. And from there, getting into bloodstream is no big deal, isn't it? So I think there is a lot that we can do to prevent, and let us all together put our efforts towards zero hospital acquired pressure injury. There are fantastic, great stories where patients have come from community with stage 4, and after months of care, they have been healed also. It takes a lot of commitment and a lot of hard work. And thanks to all those wound care nurses who are becoming specialists. And as an administrator, again, I request all the administrators, please don't give the push tool to all the assigned nurses, because they have more than enough to do and they will not be able to utilize the push tool correctly. It is better to be done by a specialty nurse or a wound nurse who can consistently look at the wound. That way they learn more and they can measure also correctly, because there is length and width and exudate. Now, how do you say moderate and small and all? So one particular person, when they look at the same thing over a period of time, they become very good at that assessment. So keep that in mind. So thank you so much, and we will see you in December, well before Christmas. We will be discussing ventilator associated pneumonia. So thank you once again, Krishna and Ramya, for a
Madam, can I ask one question?
Thank you so much, ma'am.
sorry, is there a question?
Yeah, madam, what about betadine use?
See,
Uh,
betadine is a disinfectant. I mean, there is no recommendation of betadine to be put inside the pressure injury. No, there is nothing like that. Betadine, you could be using it as a disinfectant. That's it, because you want to prevent any infection, just like any wound you could be using. But betadine dressings are something that I have not come across, no recommendation, because all the classification of pressure injury is based on the wound. What is the criteria? What is the condition of the wound? Whether it is completely neat and pink, whether you want occluding dressing. Olden time, we used to put, saline soap inside the wound to do debridement.
Glycerin, acrylflavin also we used to use.
Glycerin, I have not used. I don't know. I have only used saline for debridement. And after that, I have been abroad, so I had the opportunity to use all kinds of ready-made dressings which were available. Exposure of part with sunlight. Okay, I did not come across this particular thing. Sunlight is only for the regular vitamins to get for the patients to be in the optimal, condition. Otherwise, I have not read that in the guidelines. I did not see. Sunlight is good for everyone, even for us. We also don't get sunlight. We just move,
Madam,
close.
one more query was there. Sorry. Actually, no, with friction, when we run and all, with friction, we'll get something like vesicle. So similar kind of vesicles I have seen in ICU patient also. So how we can say it is not related to the friction, and whether we can consider that it is like a pressure injury starting?
No, I am not able to understand. Because of friction, you will get blisters. Where?
Blisters on the like when you are doing any sports activities and all, or when you are having a new sleepers, you get a like a vesicle, like fluid filled vesicles you'll get.
That is stage
Similar
2. That is stage 2. If they are on the bony prominences, if they are on pressure points, they are stage 2. Because epidermis is already out and the fluid is filled inside. So it's a stage 2 pressure injury.
Okay, thank you.
Yeah. Thank you for the question, because this was another common problem.
Yeah.
They will write stage 1. If I ask why, Madam, skin is intact. So
Yeah.
I will go and take one sterile needle, poke the blister. I said, now it is not intact. Now write stage 2. You know why? Because they are not understanding. The blister is forming because the epidermis, the dermis is already out and the fluid is getting filled inside. That is stage 2. Even I have seen use of insulin in minute doses have seen good results. Well, there are a lot of, all these things, unfortunately, unless you convert them into evidence-based practices which are published, we cannot recommend that in public forum. I'm very sure that, many of you have used Digin also on the pressure injury. That includes me, but I will not be able to talk about it because that is not documented. So good to see, but then Achama and other people who are talking about sunlight, etc., you have to prove it using a proper process of evidence-based practice and then share it. It is very important. The scientific evidence is important. You can create, see, let me tell you, in India, we have some good practices, but we don't have the patience to develop these papers in a proper process. EBP has got a certain way of addressing it and publishing it. So if we see, then why not? India definitely needs India can be a low resource country, so many patients in our country would need not very expensive dressings. Maybe something that we can do. I have heard of honey, I've heard of Digene, I've heard of, now today I'm hearing insulin. So I definitely will encourage all of you to please go and develop them into EBP. We will be more than happy to support you. We will see how best we can support. You need guidance because we do run training session on EBP with our international member from US. So they run a course, and if you are interested, do let us know. We will organize. So we have overshot the time today because of a lot of questions that we got. So it's always remains a very interesting topic. So thank you once again, Rami and Krishna, and take care. And thank you everyone for being here and being interested. Take care.
Thank
Bye bye.
you.
Thank you
Bye.
so much, ma'am.
Bye.
Bye.
Bye.